Bismillahirrahmanirrahim. Today I will talk about the management of AV canal defect. I will talk briefly about the surgical management, and after that we'll go to the anesthetic management. It is very useful to know what the surgeon is doing and what are the steps, because awareness what the surgeon is doing will give you a good idea about the course of the management and to predict the problems and to be just communicating with the surgeon, perfusionist. This communication is a clue in the successful management of patients in cardiac failure. So for that defect, AV canal defect, if it is a partial AV canal, that means, for example, this patient will have this heart, which is like an apple, so this patient has premium ASD, and the VSD is closed by the tissues of the AV valve. So this patient doesn't need anything to be done for the VSD, so just patch closure of the ASD. This is what's all that is need to be done for this child. So this is one. For a patient with complete AV canal, there is like 3 techniques for that. So the same heart, so I'm trying to make it better this time. So this one is a patient with complete AV canal defect, so there is inlet VSD and premium ASD, and there is common AV valve which is sitting here, common AV valve connecting the 2 atria and the 2 ventricles. So for this patient there is 3 ways to do it. One of the ways is just to do one, I'm gonna change the color. This is like a graft, pericardial graft or synthetic graft. So one of the ways to do it is to, I haven't changed the color, sorry. So this, okay. So put a graft in the VSD, okay, and connect the leaflets of the AV valve to this graft, okay, and then put a graft to close the ASD. So this is called 2 batch technique. This is one. The other one is called 1 batch technique, which is just like taking 1 batch, connecting it from the crest of the ventricular septum to the interatrial septum, and after that hanging or fixing the leaflets of the AV valve to that graft. So this is called single patch technique. Another way to do it is, sometimes the surgeon just decide that the VCD is too small to be closed by a batch, and in that case the surgeon will just try to fix the leaflets of the valves directly here to that septum without putting a patch here to close. So just stitches to fix the tissues of the valve to the septum, just approximation of the valve tissue to the septum here, so there is no patch here. So, and putting just 1 patch for the ASD up there. The problem with this technique, that if we have a problem with the LVOT, we said before that the problem is of this AV canal defect, that the LVOT is liable for obstruction. So with this technique, with approaching the valve to be like stitched to the crest of the VSD of the interventricular septum without putting a patch here, may cause a problem with the LVOT, with like the blood coming out from the left ventricle to the aorta. So these are the main techniques for the repair. I'm not saying that these are the only surgeries that can be done for a child who has AV canal defect, because we said before, if this patient is unbalanced AV canal and the left ventricle is tiny or small, hypoplastic. So for this patient, we may just decide to go for a single ventricle physiology, which will be a lot different than what we are doing now for this child. Okay, so while doing that, the surgeon will try to fix the AV valve to septate or separate this AV valve into two valves. So if we have a big AV valve here connecting the two atria and the two ventricles, we said that this valve will have abnormal configuration of cusps, something like that, and of leaflet, sorry, so like that. So one bridging leaflet, superior bridging leaflet, inferior bridging leaflet, left. So this is left mural leaflet, this is right mural leaflet, this is superior bridging leaflet because it is bridging the septum, which will be something here under the valve, and this is the inferior bridging leaflet. So this is completely abnormal leaflet. So if I'm gonna put a patch here and close this area, I will have like something like a cleft or opening here and opening here. So I have the surgeon has to close this defect by stitches, because if he left it like that, the valve will be regurgitant. So the surgeon will try to make two valves by making stitches and by hanging these leaflets to the grafts according to the three techniques that we talked about before. So the surgeon will try to approximate this area by stitches and close it. So the main valve will be here in this area like that. The most important, of course, is the left AV valve, which is in place of the mitral valve. So if the surgeon tries to close this valve and approximate this and close the cleft here by stitches, there will be a big difference between a patient who has this picture. So this is a patient who has a small left mural leaflet, so for example, for this patient, if the surgeon is to take the stitches here, it will be difficult for him to create a valve which is not regurgitant and the same not stenotic valve. So that's why a small left mural leaflet is a challenge for the surgeon, and this can appear in the echo. In the gastric view, this can give a picture of the left mural leaflet, and also for the three-dimensional can be helpful. And also looking at the papillary muscles down connected to this left mural leaflet can give an idea if this leaflet is big or small. For example, if the two papillary muscles are very near to each other, that means, or they are just one, means parachute valve, that means the left mural leaflet will be small, and this will be challenging for the surgeon. So the papillary muscles and the size of the left mural leaflet can give an idea. So the idea of this is I will predict that the repair will not be perfect after, so the patient may come out of bypass with some regurg or some stenosis. But for left mural leaflet like that, which is big, so the repair will be a bit easier on the surgeon, although some of them will have some regurg, and this is like acceptable for like mild regurg after a repair like that, but at least I will not come out of bypass with moderate or severe regurg in the left AV valve. So this is about the surgical techniques, and of course the tricuspid valve, or sorry, the right AV valve will be closed, the cleaflet will be closed in the same way. I'm not a surgeon, but I'm just trying to highlight the points that is of importance to us. Also, if this valve has some cords, some cordi, which are like crossing the ventricular septum. So for example, I have this valve here. Okay, so this is the septum before putting the graft, and this valve, the leaflets, the bridging leaflets and the mural leaflets, so some of the cordi from this side came and attached to that side, or some of the cordi from this side came and attached to that side. So for the surgeon to close that defect, the surgeon may not be able to do that because of the cordi, so he has to cut the cordi. Maybe if it is not so important, cut this one or cut this one, or the surgeon may cut it and connect it again to the graft or to the patch to keep the valve competence. So of course, for a valve like that, when the surgeon was like obliged to cut some of the cordi of the leaflets, so this valve will be more liable for regurgitation after the repair. I think that's enough for the surgical management, and the next video we're gonna talk about the anesthetic management. Thank you very much, and assalamu alaikum.